Welcome to Module 4, General Cleaning. This is the fourth module in the training program developed in support of the best practice document on environmental cleaning for the prevention and control of infections in all healthcare settings, developed by the Provincial Infectious Diseases Advisory Committee. Healthcare settings are encouraged to work towards best practices in an effort to improve quality of care. Module 4 is the largest of the 6 modules and is divided into 3 parts. Part A deals with cleaning principles. My name is Keith Sofa, Manager of Housekeeping and Linen at Homewood Health Centre and President of the Canadian Association of Environmental Management, and I'll be your presenter for Part A of this module. After completing this module, you should be able to identify factors that determine frequency of cleaning, to correctly sequence tasks for cleaning, to demonstrate proper procedures for different cleaning applications, describe other considerations in environmental management such as handling of waste, the management of sharps, and dealing with spills of blood and body fluids. Part A of this module addresses the first objective. You are encouraged to take a few moments after this module to review the accompanying DVD, which demonstrates a number of cleaning scenarios. Your manager or supervisor may also wish to consider the use of live demos. The focus of this module is on hospital clean, and the principles we describe apply to all areas of the facility where hospital clean is required. Let's review the definitions of hotel clean and hospital clean. Hotel clean is a measure of cleanliness based on visual appearance that includes dust and dirt removal, waste disposal, and cleaning of windows and surfaces. Hospital clean is a hotel clean plus high-touch surfaces in patient, resident, client care areas are cleaned and disinfected with hospital-grade disinfectant. Non-critical medical equipment is cleaned and disinfected between patients, residents, clients, and cleaning practices are periodically monitored and audited with feedback and education. There are several factors that influence the frequency of cleaning. Are the surface high touch or low touch? A doorknob will require more frequent cleaning than a windowsill. What type of activity is taking place in the specific area, and are there risks associated with that activity? For example, a critical care area is more likely to have high-risk activities than an office area. How vulnerable are the patient's residents in the area? Patients in the intensive care unit may be more susceptible to infection than a patient in a resident or another unit. What's the likelihood that the area is going to be contaminated with body fluids under normal circumstances? This may vary depending on the setting. Finally, are there antibiotic-resistant organisms such as MRSA or VRE present? All of these factors must be taken into consideration when determining the frequency of cleaning. Further, along in this module, we will review the risk stratification matrix, which will assist in making these decisions. High-touch surfaces are those that have frequent contact with hands. Examples: doorknobs, elevator buttons, telephones, call bells, bed rails, light switches, computer, keyboards, etc. High-touch surfaces in care areas require more frequent cleaning and disinfecting than minimal contact surfaces. Cleaning and disinfection is usually done at least daily and more frequently if the risk of environmental contamination is higher. Example, in intensive care units during outbreaks. How many high-touch surfaces can you identify in this picture? Bed rails, the call bell, handles on the bedside tables, and the bed controls are all high-touch surfaces. What are the high-touch surfaces in this picture? Think about where your hands or the patient's resident's hands will have frequent contact. The handles on the cupboard and the area just around these are more likely to have frequent contact. What about this picture? Doorknobs, door frame, and light switches are all high-touch surfaces. Low-touch surfaces are those that have minimal contact with hands. Examples are floors, walls, ceilings, mirrors, and windowsills. Require cleaning on a regular but not necessarily daily basis when soiling or spills occur and when a resident is discharged from the healthcare setting. Many low-touch surfaces may be cleaned on a periodic basis rather than on a daily basis if they are also cleaned when visibly soiled. High-touch versus low-touch surfaces. The frequency of cleaning and the level of cleaning are dependent upon the risk classification of the area to be cleaned. Let's review the risk stratification matrix referred to previously. The first step is to categorize the factors that impact on the need to clean. Factors that will impact the frequency of environmental cleaning include probability of contamination with pathogens, the vulnerability of clients, patients, residents to the infection, and potential for exposure. Once you've done that, you can start to use the charts. The probability of contamination is categorized as heavy, moderate, and light. An area with a heavy probability of contamination would be routinely exposed to large amounts of blood and other body fluids. Two good examples of this are the emergency room and labor and delivery room suites. All bathrooms would be classified as moderate risk since under normal use. They may become contaminated with blood and body fluids, but not routinely. And of course, areas such as offices and lounges are less likely to become contaminated with blood and body fluids. At least we hope. The next two factors to consider in the risk stratification are the vulnerability of the patient, client, residents population from more to less susceptible, and the potential of surfaces to become in contact with hands. As described earlier in the module, high-touch surfaces are those that have frequent contact with hands, while low-touch surfaces have minimum contact. Based on the probability of contamination and the susceptibility of your clients, patients, residents, you can then use this chart to come up with a total score that can help determine the frequency of cleaning by using the chart on the next slide. This chart will then provide guidance on the frequency of cleaning. A risk score of 7 is considered high risk, and at a minimum, cleaning should occur after each case, event or procedure, and at least twice per day. A score between 4 and 6 is moderate risk, and these areas should be cleaned at least once daily. A score of 2 to 3 is considered low risk, and these areas should be cleaned according to the fixed schedule. For example, an office area may be on schedule for a once-weekly cleaning. In all cases, the frequency described is a minimum, and additional cleaning may be required, such if it's grossly soiled. Here's an example of how the matrix can be used in a hospital setting. In an intensive care unit, the probability of contamination is heavy, for a score of 3. The potential for exposure is high for another 3 points, and the patient in the ICU are more susceptible to infection, so add another point for a total of 7. In this area, clean at least twice per day and more frequently if gross soiling occurs. In the example of a resident activity room in a long-term care home, probability of contamination is moderate, equaling 2. Potential for exposure is high, in high-touch areas, equaling 3. Vulnerability of the residents, those participating in activities, may be considered less susceptible, equals 0. The total score being equaling 5. Clean at least once daily and additionally as required if gross soiling occurs. Here is your first learning checkpoint. Look at the following list of items and identify whether the item is high touch or low touch. Toilet handle, soap dispenser, baseboard, wall, bathroom mirror, faucet handles, window coverings, ceiling lights. The correct answers are toilet handle being high, soap dispensers high, baseboards low, wall low, bathroom mirror low, faucet handles high, window coverings high, low, depending on the setting. Use the risk matrix to determine this. Ceiling lights are low. In some settings, these surfaces may be either high or low touch, depending on where and how they are used. It is important that the risk stratification matrix be used to identify the frequency of cleaning required.